Welcome to this presentation. This will be a lecture on physician burnout. This will be the lecture outline, introduction and terminology, prevalence of physician burnout, burnout in ICD-11, risk factors for physician burnout, consequences of physician burnout, rating scales, management of physician burnout, burnout and resilience, burnout and depression, burnout in female physicians, physician suicide. We will conclude by going through 5 multiple choice questions based on the material covered. The concept of burnout was introduced by Herbert Freudenberger, a New York-based psychologist, in 1974. He defined burnout as a state of mental and physical exhaustion caused by one's professional life. The pioneer in the systematic study of burnout has been Christina Maslach, professor of psychology at University of California, Berkeley. The increasing awareness of the high prevalence and wide-ranging consequences of physician burnout have prompted healthcare organizations to take remedial measures. Burnout is now a diagnosis in ICD-11. ICD is the International Classification of Diseases, and ICD-11 is the 11th edition. Burnout as a single word noun refers to the cessation of operation of an engine due to exhaustion of fuel or the failure of a device through overheating. It also refers to physical or mental collapse caused by overwork, or it can refer to a person who is suffering the effects of such overwork. The two-worded verb burn out means to destroy by fire or heat, to become exhausted or worn out by overwork or overuse. The diagnosis of burnout in ICD-11 is a single word, but it is hyphenated. Some have objected to the term burnout as it seems to imply weakness or non-resilience on the part of affected physicians, thus shifting focus away from systemic or organizational factors, which are usually much more to blame. Also, colloquially, burnout is a slang for a drug abuser. So, alternative terms have been suggested. These include moral injury, moral distress, and occupational stress injury. However, as almost all research on this topic have used the term burnout, and as burnout is now a diagnosis in ICD-11, usage of this term is likely to continue for the foreseeable future. In this lecture, the term physician refers to all medical doctors, the way in which this term is used in the US. In the UK and many Commonwealth nations, physician is a designation applied to doctors working in general medicine and medical subspecialties, in contrast to the term surgeon that is applied to doctors working in general surgery and surgical subspecialties. Most studies on the topic of burnout among doctors have employed the phrase physician burnout, and so I have retained that term for this lecture. Depersonalization in burnout literature, for example in the Maslach burnout inventory, refers to the impersonal attitude of a physician towards a patient, so that the patient is seen more as an object than as a person. In psychiatry, however, the term depersonalization refers to a sense of unreality and detachment with respect to one's own feelings, thoughts, and actions. I have given a couple of examples. Depersonalization is associated with derealization, where the surroundings seem unreal, detached, lifeless, etc. Depersonalization and derealization are seen in severe anxiety states and dissociative disorders. We will now look at the prevalence of physician burnout. A 2018 survey in the US by the Physicians Foundation revealed that 78% of physicians reported feeling sometimes, often, or always burned out, an increase of 4% since the previous survey 2 years earlier. The prevalence of burnout was higher among female physicians than male physicians. A 2019 survey by the British Medical Association observed that 80% of doctors were at high risk of burnout, with junior doctors and general practitioners showing the greatest risk. A systematic review found that the prevalence of burnout was over 50% among US physicians, and that it affected the whole range from medical students to experienced clinicians and across specialties. Burnout appears to be more common in certain so-called frontline specialties such as emergency medicine, internal medicine, and primary care, and less common in some specialties such as dermatology, pathology, and ophthalmology. Overall, the prevalence of burnout among psychiatrists seems to be intermediate. Factors that may increase the risk of burnout include understaffed or unsafe wards or community teams, high patient turnover, recent patient suicide, etc. Burnout is now a diagnosis in ICD-11. The code is QD85. Burnout is not a medical or psychiatric diagnosis in ICD-11. It is included under problems associated with employment or unemployment. According to ICD-11, burnout is a syndrome resulting from chronic workplace stress that has not been successfully managed. It is characterized by three dimensions: energy depletion or exhaustion, negativism or cynicism related to one's job, and reduced professional efficacy. Burnout is specific to the occupational context and is not applicable to other areas of life. We will now look at the general risk factors for burnout. These were outlined by Christina Maslach. She identified 6 general risk factors. These include excessive workload or demand, reduced control or autonomy, lack of rewards or positive feedback, lack of fairness, an unsupportive work community, and conflicting values. In addition, there are specific risk factors pertaining to physician burnout. The increase in prevalence of burnout among doctors has coincided with and is highly related to the increase in the use of electronic medical records. Many doctors are spending more time in front of computers than on direct patient care. Physicians are increasingly involved in clerical work such as filling forms or making phone calls to get insurance pre-authorization. Such non-clinical duties seem to have a demoralizing effect on physicians. Other specific risk factors for physician burnout include long unsocial working hours. Medicine is an ultra-high responsibility field dealing with life and death issues on a routine basis. It is a profession where errors with huge consequences are both unpredictable and inevitable. Death of patients can be traumatic, especially if the doctor has known the patient well, but doctors have to move on without giving themselves adequate time or space for grieving. In terms of age as a risk factor, physician burnout is more common in younger doctors early in their career compared to older doctors. And physician burnout is more common in female doctors. There are also several non-specific risk factors that can contribute to physician burnout. An unsupportive hospital management which prioritizes productivity and profit over staff well-being. Hostile colleagues, so the work environment is a dog-eat-dog competitive one. Sexual harassment at work, this is especially the case for female physicians. Chronic financial stress. Many doctors have huge, especially educational loans, which take up to even decades to settle. Having young children at home has been shown to be a risk factor. What are the consequences of physician burnout? Physician burnout can have a negative impact on the services provided, reduced quality of care, increased medical errors, reduced patient satisfaction, increased staff turnover, and increased cost. The consequences of physician burnout on affected physicians include reduced quality of life, increased risk of alcohol or substance misuse, increased risk of depression, self-harm or suicide. The physician deciding to become part-time or even deciding to leave the medical profession because of inability to cope. We will now look at rating scales that are used in studies of burnout. In this slide, I have listed several such rating scales. Those who are interested can pause and note down the details. We will look in a bit more detail into two of these rating scales, the MASLAC burnout inventory and the well-being index. The MASLAC burnout inventory, or the MBI, is the most commonly used and best validated tool to assess burnout in different professions, including medicine. The MBI was developed by Christina Maslach and Susan Jackson. There are different versions of the MBI. The one that is used in studies of physicians is the MBBS or the Human Services Survey. Other variants include GS or General Survey and ES or Educator Survey. The MBL has 22 items across 3 dimensions, 9 items covering emotional exhaustion, 5 items for depersonalization, and 8 items relating to personal accomplishment. Each item is scored on a 7-point scale ranging from 0 to 6. Each dimension is scored separately, so each participant will have 3 scores rather than a single overall score. In this slide, I have given one sample item from each of the dimensions. Those who are interested can pause and note down the details. The items in section C, that is the dimension of personal accomplishment, are reverse scored so that a high score in these 8 items is an indicator of a positive occupational experience, while high scores in the other 2 dimensions suggest burnout. The Well-Being Index is a screening tool to help identify health professionals in distress. This was developed at the Mayo Clinic. There are different versions for different professionals, such as medical students, physicians, and nurses. Areas covered in the Well-Being Index include burnout, depression, fatigue, stress, physical health, and quality of life. We will now look at the management of burnout. The management can be divided into strategies at the level of the individual physician and strategies at the level of the organization, that is the healthcare organization or employer. What can the individual physician do? Discuss proactively with the management about problems at the workplace and suggest changes that can be made. Doctors should take care of their own health. Adequate sleep, healthy eating, and regular exercise. They should have periodic checkups. So, any doctor should actively see another doctor if they develop new physical or mental symptoms without unnecessary delay. Doctors tend to ignore their own health needs. Many do not see their general practitioner or primary care physician. Some do not even have a GP or PCP. Physicians should be aware of warning signs of burnout in oneself and in colleagues. These include uncharacteristically becoming more irritable, angry, and cynical towards patients, carers, or colleagues, excessive guilt, no longer enjoying work, easily drained emotionally and physically, and losing self-confidence. Physicians should utilize support systems that are available locally, nationally, and even online. Doctors should maintain a healthy work-life balance. So the physician should devote time for non-work activities, including family, hobbies, going on holidays, and spiritual or religious activities if one is so inclined. Physicians can consider yoga, mindfulness-based activities such as meditation, etc. In terms of organizational strategies, management should proactively ask for, listen to, and address any problems faced by physicians. Use of electronic medical records should be doctor-friendly. Avoid unnecessary documentation requirements. Ensure adequate staffing levels. Ensure that working hours and workload are reasonable. Ensure fairness and respect. Work environment should be non-discriminatory and should be responsive to specific staff needs. Other organizational strategies include regularly assessing staff well-being and satisfaction, ensuring staff safety, supporting physicians in their career development, such as leadership skills training, mentoring, etc. Encourage physicians' peer group networks. Provide private space where doctors can meet, such as a physician's lounge or a doctor's common room. Have a designated chief wellness officer in the organization. Make available confidential resources that physicians with burnout can access. Burnout reduction programs are relatively inexpensive, and if properly implemented, they can be very cost-effective for organizations. In this slide, I have listed some useful resources and programs available for physicians. Those who are interested can pause and note down the details. We will now briefly look at burnout and resilience. Resilience is the ability to quickly recover from, adapt to, or even thrive in the face of adversity. Physicians as a group, to begin with, are more resilient than the general population. This has been shown by surveys of pre-medical and pre-clinical medical students compared to matched controls. But the changing nature of medicine over the last several years has increased the prevalence of burnout even in this resilient population. There are rating scales for assessing resilience. For example, the Connor-Davidson Resilience Scale. Resilience building strategies may help protect against burnout. The General Medical Council in the UK has recommended that resilience training be part of the curriculum for medical students. Some factors that promote resilience include optimism, perseverance, self-compassion, valuing one's role, supportive relationships, effective stress and time management, mindfulness, meditation, etc. There are online training resources for resilience, and I have given an example. We will now look at burnout and depression. There is significant overlap between the two. It has been suggested that burnout is a subtype or milder variant of depression. The more severe the burnout, the more blurred the distinction between burnout and depression. Risks of both burnout and depression are higher in physicians compared to the respective risks in matched controls. Among the three dimensions in the Maslach burnout inventory, emotional exhaustion appears to best correlate with depression. Burnout is restricted to the work context, while depression dominates all aspects of an individual's life. Depression needs specific treatment, usually medication or psychotherapy, while burnout usually responds to external organizational improvements and simple personal well-being strategies. It should be noted that burnout is a significant risk factor for subsequent depression. The next topic is burnout in female physicians. Overall, burnout appears to be more common among female physicians. This is partly explained by the lower average age of female physicians compared to male physicians. As we saw earlier, burnout is more common among younger physicians. Among physicians experiencing burnout, female physicians report more emotional exhaustion, while male physicians report more depersonalization. Female physicians are more likely than male physicians to become part-time or even leave the medical profession as a consequence of burnout. Risk of alcoholism due to burnout is higher among female physicians than male physicians. Female physicians are also at much greater risk of sexual harassment, ranging from sexist comments to actual assaults, which is a risk factor for burnout. Female physicians have more breaks in their careers, leading to slower progression, so they are very underrepresented at the higher levels of academia and clinical practice. For example, as deans, professors, or heads of department. This can lead to a sense of reduced personal accomplishment, which is one of the dimensions of burnout as per the MBI. Female physicians experience more discrimination both at work and also outside. For example, there are numerous anecdotes of female physicians, especially from ethnic minorities, working in the US, being snubbed even when they offer voluntary assistance during in-flight medical emergencies. So they have to face with statements such as, "We want a doctor, not a nurse," or "Show your ID," etc. The final topic is physician suicide. This topic has been well studied in the United States. About 400 physicians die by suicide in the US every year. Both male and female physicians have higher suicide rates than their respective counterparts in the general population. Overall, the suicide rate in physicians is about twice that in the general population. The male-female ratio for suicide among physicians is about 2 to 1, while the male-female ratio for suicide in the general population is about 3 to 1. Risk factors for suicide among physicians include those that apply to the general population. Untreated mental illness, especially depression and bipolar disorder, alcohol or drug misuse, personality disorders, social isolation, relationship problems, financial difficulties. In addition, there are risk factors that are specific to doctors. So the additional specific risk factors include easier access to lethal drugs and knowledge about the lethal dose of such medication. Perhaps for this reason, pharmacists who also have both access and knowledge about drugs have a suicide rate that is higher than that in the general population. Certain personality traits such as perfectionism may be overrepresented among doctors. So any suicide attempt by a doctors is thoroughly planned and so likely to succeed. Pending or ongoing disciplinary proceedings or investigations against the doctor by the regulatory agency, for example by the General Medical Council in the UK, may be a risk factor for physician suicide. Suicide can happen in the workplace, and I have given some examples. Physicians who die by suicides, when compared to suicides in general, are more likely to have had problems at work, more likely to have had untreated or undertreated mental illness, not seeking treatment for fear of losing license to practice, self-medication with either an inappropriate drug or an inadequate dose, are more likely to show benzodiazepines or barbiturates in their blood, which is a reflection of easier access to such medication for doctors, and they are less likely to have family history of suicide. That brings us to the end of this presentation. Before we conclude, we will go through 5 multiple choice questions based on the material covered. Question 1. Which of the following is correct regarding burnout among physicians? There are 4 options. Please go through the options and make your choice. If you want, you can pause. And the correct answer is B. Burnout among physicians is more due to organizational factors than individual ones. The other 3 options are not correct. A is incorrect because it is MBI, or the Maslach Burnout Inventory, which is the most commonly used scale for assessing burnout among doctors. BDI is Beck Depression Inventory, and it is a scale that is used in depression. Option C is incorrect because burnout is more common among female physicians. And D is incorrect because burnout is more common in younger physicians. Question 2. Which of the following is not correct regarding suicide by physicians? Please go through the 4 options and make your selection. The answer is B. So B is the statement which is not correct. The other 3 options are correct. B is incorrect because suicide rate among physicians is higher than in the general population. Question 3. Which of the following is correct regarding burnout? Please go through the options and make your choice. The correct answer is A. Burnout among physicians has been linked to an increase in medical errors. The other three options are incorrect. B is incorrect because burnout is not included in DSM-5. C is incorrect because although burnout is included in ICD-11, it is not included as a mood disorder. It is a disorder associated with employment. D is incorrect because the prevalence of burnout among physicians is higher than in matched non-physician controls. Question 4. Which of the following is not a strategy for reducing burnout among physicians? Please go through the 4 options and make your selection. The correct answer is D. So D is not a strategy for reducing burnout. Increasing use of electronic medical records is consistently among the top reasons cited by physicians as causing burnout. Final question. Which of the following is not one of the 3 dimensions of the MASLAC burnout inventory? Is it depersonalization, emotional exhaustion, personal accomplishment, or workload? The answer is D, workload. So workload is not one of the 3 dimensions of the MBI, while the other 3 are. That brings us to the end of this presentation. Hope you found the information useful. Thank you for watching.